Now, my problem with it is that there's a lot of false pocketing. So what happens is that it depends on the depth and the position of the implant placed, and also on restoratively the length and the contour of the abutment. So if you have an overly contoured abutment, you might actually have less pocketing, that you can see or that you can probe, but that doesn't mean that there isn't a pocket there. So that means that you're not actually diagnosing it very well. Then we look at crestal bone loss. So this is the idea of taking periapicals, looking at bone loss radiographically, and then measuring that bone loss and comparing it to previous x-rays to see whether or not there's any bone loss. Now you can see here that I like this kind of method where you actually measure the implant length and then you divide the amount of bone loss by the length to create a percentage. But the problem is that there are no agreed guidelines. We have no idea who has the correct guideline, what is, early, moderate, or severe bone loss. Another problem is that actually every time you place an implant, you will get natural marginal bone loss of around 1 millimeter or 2. So how can you differentiate between natural marginal bone loss and actually pathogenic bone loss, which could lead to periimplantitis? And then lastly, the problem is that we're taking these 2D periapicals, which are only displaying interproximal bone. So what happens if there's buccal or lingual bone loss? We're not able to see it. And it's quite difficult to be able to justify taking 3D CBCT scans once a year to check for buccal or lingual bone loss around an implant. So we most likely don't do that. Then we've got the classic bleeding on probing. 91% of implants will have some bleeding on probing if they have periimplantitis. My problem, it's subjective. It really depends on the clinician, how hard they're probing. It's invasive. And lastly, you're actually spreading bacteria, which obviously you don't want to if there is an infection present. And then we've got lastly, the presence of suppuration and or a fistula. So basically pus coming out of the pocket. Now, in my opinion, it's too late. If a patient's having pus coming out of their pocket, then there's a lot of problems going on here and a lot of treatment has to be done. And the idea is to not get to this stage ever. You don't want to have this type of problem. So just a quick recap of the problems with the quantitative methods are that they're not standardized. Every country has different criteria, which means that if a patient's going between numerous clinicians, we never have a proper, diagnosis of that patient. And that leads on to the fact that it's subjective. Every clinician will actually measure things differently. And it's all based on our eyesight, basically. It's inaccurate. And another problem is you're not actually able to monitor treatment or progress. So if you are to diagnose periimplantitis, what is your end goal? Is the idea that you're meant to have absence of bleeding on probing? Is that a good enough kind of treatment aim? Or is there another thing that we can actually monitor and track? And lastly, you're often relying on clinical symptoms. And by this point, it's often too late if the patient's actually having problems with their implant. So if we move on to the kind of more quantitative methods, the first one is the idea of biomarkers. So there are numerous biomarkers that are found in the saliva and the gingival crevicular fluid inside the mouth. And one of the kind of biggest biomarkers at the moment is AMMP8. So AMMP8 is a major collagen-lytic enzyme, and it causes active periodontal and peri-implant degeneration. So it's a really great biomarker that we can actually find in the saliva and the gingival crevicular fluid, and it will show us whether or not there's any type of collagen breakdown. Now, what's good is it's point of care. So it takes about 5 to 10 minutes. The patient can stay in the chair and you will have the results within 10 minutes. It's early detection of subclinical inflammation. So this means that it's often not symptomatic. The patient has no idea that they have this inflammation or the early beginning of periimplantitis. And you're able to kind of detect it and stop it before it develops into anything worse. And then it also indicates active periodontal tissue breakdown. So if you're having kind of collagen breakdown early on and you have elevated levels of it, then that suggests that you have periodontal tissue breakdown, and that will suggest that there is some periimplantitis going on. And so another really important thing is the ability to diagnose and monitor treatment outcomes. And we'll go on to this in the next slide. But the idea that if you're able to diagnose a patient with a number and say, okay, you have elevated numbers of levels of AMMPA, we want to get you down below 20. And so every 3 months, we're going to keep on doing this test until you get below 20. This is a treatment outcome that is easily kind of achievable. There's an easy way of tracking it, and it gives a lot of motivation to the patient as well. And then lastly, it's non-invasive. So unlike bleeding on probing, where you're literally probing the gum, this is non-invasive. So the only kind of flaw I would say is that additional machinery is needed. You will need to have the machine in the practice, but in my opinion, it's an investment which will pay back very quickly. And it's something that I genuinely don't think I could work without anymore. So if you're comparing AMMP8 to other biomarkers in the saliva and the gingival crevicular fluid, if you look at the graph on the right, you can see that AMMP8 has the best sensitivity and the best specificity compared to any other oral biomarkers, and also are kind of gold standard for diagnosing peri-implantitis at the moment, which is bleeding on probing. So you can see here the bleeding on probing is not as good as the AMMP point of care test, which is all the way up here and very stable. So AMMP8 has been shown to be more accurate than any other biomarker, and also more accurate than qualitative diagnostic methods currently available to us. So this is how it kind of looks. This is your machine. There's 3 different types of tests. You've got the implant safe test, which is specifically for implants, and you place a little strip basically into the pocket where the implant is. And then you've got the oralizer, which is more general. It's more of like a screening tool to see if there's any elevated collagen breakdown in the mouth generally. And the last is specific for periodontal disease, so the perio-safe, and that's for patients who have periodontal disease on specific teeth. And again, you just kind of put a small litmus paper inside the pocket. And here you can see this personalized prevention plan that can be created and followed by the patient and the clinician, and that can be carried on from clinician to another clinician, and it's very easy to read and convert. Then we've got other ones, which are oral microbiome testing. So the idea of looking at the bacteria, we all know that peri-implantitis originates from basically pathogenic bacteria surrounding itself around the implant and causing inflammation and infection. So with oral microbiome testing, it's looking at the idea that with peri-implantitis, you have higher counts of 19 bacterial species, and you can see them all here. And interestingly, these 19 bacterial species generally they're very low in diversity, and there's very distinct signatures between mucositis and peri-implantitis. So that technically means we could be able to differentiate between perimucositis and peri-implantitis with oral microbiome testing and looking at specific bacteria, particularly Fusobacterium nucleatum, P. endodentalis, and T. forsythia, to see whether or not there's elevated levels of them in the mouth. Problem is, it's not point of care. It needs external testing, which can take a couple of weeks. It's expensive, and the research is not fully established there. So can it actually impact your treatment? Can you justify charging your patient for that when you don't really know how it's going to help? And also another problem is the oral microbiome is impacted by a lot of other factors. So you have to take into account the fact that maybe the patient's smoking, they have poor nutrition, they're not brushing their teeth, and that will impact the oral microbiome, and it might not necessarily be indicative of peri-implantitis. So this one take with a grain of salt, in my opinion. And this is something that I'm looking into, but I'm still not completely convinced in. And then lastly, the idea of pro-inflammatory cytokines. So we know that with peri-implantitis, there is inflammation and there are elevated levels of certain interleukins, so IL-1, IL-8, tumor necrosis factor, and obviously the MMPs that we were just discussing. So technically, we should be able to potentially look and screen patients for increased levels of these pro-inflammatory cytokines, and that could indicate inflammation in the mouth. Now, the problem is that mucositis and peri-implantitis both have inflammation, so it's very difficult to differentiate between the two of them. It's expensive. Again, additional machinery is needed. As I said, you can't differentiate between mucositis and peri-implantitis, and you also can't differentiate between local and systemic inflammation. And I've tried this test a few times, but the problem is that if a patient has, for example, chronic systemic disease like rheumatoid arthritis, their levels will be elevated, but that doesn't mean they have peri-implantitis. So this has not been refined enough, and still a lot of research needs to go into this. But this is, again, something that is in the works, I think. So in conclusion, There are qualitative methods for diagnosing peri-implantitis. They're subjective. They're not standardized. There's not, one criteria that every country and every clinician can follow, and that's a major problem. And often we are diagnosing problems far too late and when clinical symptoms have already occurred. Oral microbiome testing, it's very promising, but it's very premature. And there's not very much research into the clinical application. Same with inflammatory markers. It's limited research, unable to differentiate between systemic and local inflammation. And lastly, AMMP8 biomarker testing, in my opinion, is one which has had over 500 published papers. It's very there's a lot of research that's been going into it. And it's showing that AMMP8 is the most stable, most accurate diagnostic method compared to other quantitative and qualitative methods. And using the biomarker testing, this is what I use myself in the practice now. I'm able to give a number to the patient and say, okay, your level is 60 and we want you to get down to 20. This is how we're going to get you down to 20. And you create a treatment plan. And I think in my opinion, this is the future of dentistry and the way that we need to be starting to diagnose peri-implantitis and even perimucositis as well. Thank you for listening. I know it was a quick one, but if anyone has any questions, please let me know.